Alport syndrome, no, type 4 collagen of the glomerular basement membrane is defective because of the mutation of the genes controlling the type 4 synthesis. So 80% of cases it is X-linked, and alpha 5 chain is defective, and 15% of cases it is autosomal recessive, where alpha 3 and 4 both can be defective, and another 5% you have autosomal dominant. Previously we called it something different, thin basement membrane disease presenting with the recurrent benign familial hematuria in something. Now they are not no longer benign, no longer a separate entity. They are the part of the Alport syndrome presenting in dominant fashion, comprising around 5% of the Alport. It is more common in the boys. The commonest presentation is your hematuria, hypertension, and proteinuria. And later on, you have disease presence in usually less than 10 years or around, and later on the disease advances, and you have you can have the 50 to 80% cases you do have the high frequency auditory deafness. In another 30 to 50% cases, you have eye involvement in the form of anterior lenticonus, retinal flecks and dots, and your corneal erosion and cataract. So these are the presentations like. So the dominant cases, they have less amount of the your hematuria, and your very mild sort of presentation. In recessive cases, 75% cases may have hematuria. In X-linked cases, universally it's a boy usually, because one X is defective, other X cannot compensate. So thereby there is X-linked diseases are more common in the male, and thereby they have 100% hematuria and 100% proteinuria, maybe a little bit less aggressive at the beginning. Female have milder presentations, but it's possible to have the disease in the female. And ESRD in the course of time is a grave consideration. So it's possible in 50% cases by 25 years, and 80% cases by 40 years, and 100% cases virtually in your 60 years or so in cases of male. And in female it is not the case. And how to diagnose? In early stage you have thinning of the basement membrane by electron microscopy, and later stage you have lamellation. There can be thickening, weaving, basket weaving, and a few more other pathologies. There can be a little bit extension of the disease from the GBM to the neighboring structures, maybe mesenterium and tubule, and so disease can be extensive from the kidney to the esophagus. Esophageal leomatosis is common. Bronchial involvement is common. Again, in presenting with the cough, dyspnea, hemoptysis, and so forth. And gut and the involvement is possible. And then elliptocytosis, the WBC possible. And aortic aneurysm in AMMECR disease, and or call for S6 disease, and there will be continuous microdeletion, more extensive disease, even in the brain is possible. So these are the presentations. The differential over here are the Hanach syndrome. You have your hereditary angiopathy, nephropathy, and aneurysm and muscle cramps caused by the call4 A1 genes, and alpha 1 component chain is defective over here. These children can have cyst apart from the hematuria. And another differential is the citrate nephropathy, CFR5 gene in this involved, and autosomal dominant inheritance, microscopic hematuria, and they have progressed to ESRD by 5th decade or so. And MAYH related disease is also a differential. You have the autosomal dominant inheritance, you have microscopic hematuria, you have proteinuria 25% of cases, you have macrothrombocytosis and macrothrombocytopenia, and you have W white blood cell has Dolly bodies, and you can have the sensorineural hearing defect, cataract like in Alport syndrome. So these are the differentials. Apart from that, you can have fibrillary nephropathy or glomerulonephritis due to the fibronectin deposition due to the defect of the F1 gene. So these children also have similar sort of presentation, but the underlying cause, the genetic defect, is different. And by fifth decade, they also can develop ESRD. So the H hepatitis C virus, an autoimmune disease, malignancy, diabetes can be associated with the fibronectin disease. And diagnosis of the fibronectin disease is the fibrils and stains for the fibrillars, the IgA, you have lambda and kappa light chains in the mesenchyme. The confirmation of the diagnosis is by DNA J heat shock protein, DNA JB 9 isolation. So your prognosis of this disease as fibronectin disease is quite aggressive disease. Prognosis is poor. Transplant is the answer, and recurrence is possible. And apart from that, you have hematuria syndrome group, IgA nephropathy, C3GP, the membranous nephropathy, and lupus nephritis, acute post-streptococcal. It is usually single-time business. Recurrence is not easy common. And then you have the IgA vasculitic nephropathy, what we call in the earlier henoxylin purpura nephritis. So how do you treat Alport? Alport syndrome is not an inflammatory or infective disease. It is a genetic mediated, little bit of the GBM alteration. You have little bit of proteinuria, little bit of hematuria and hypertension, renal impairment. So no rule of immunosuppression. No, you give the RASI, you give ACE inhibitor or ARB, either, and you control the hypertension. You other symptomatic and supportive measures, and your trial medications are over there. They are not useful. Anti-RNA-21 antioxidants like bardoxolone, and a few more drugs are on the way, and people are trying. But the good amount of time you cannot succeed, because as I said earlier, it is not an inflammatory process. Immune suppression has no rule. And so what you do, you wait if patient progresses by, it's quite take 50 days, 6 days, quite a long. So what you do, you go for the transplant recurrent possible, those possible 5 to 3% of cases. What happens over here, anti-GPM antibody develop in these transplanted cases, so leading to the RPGN and graft loss. Thereby those cases are to be treated in RPGN protocol and to be retransplanted again.